I'm Dr. Golden. I'm the site director for infectious diseases at the St. Raphael campus of Yale New Haven Hospital. And I'm going to give some information today about diagnosis and management of prosthetic joint infections. So just to give some background, as the population ages, more and more patients are undergoing joint replacement surgery. At the present time, there are over 285,000 hip replacements and over 600,000 knee replacements performed annually in the U.S. That translates into about 7 million Americans who are currently living with artificial hips and knees. Virtually any joint can be replaced, and while hips and knees are the most common joints that are replaced, ankles, shoulders, and elbows are also joints that can be replaced in the appropriate setting. At the moment, it's estimated that by the year 2030, there will be 11 million people in the U.S. Who will have had either hip or knee replacement surgery. So I just want to show a quick slide about terminology. So when the surgeons manage arthritic joints or destroyed joints, there are basically 3 different types of procedures that can be done for hip replacement. So there's something called a total hip arthroplasty, or THA, where both the femoral head and the acetabular surfaces are replaced. And at the bottom of the slide, you can see the cup, the acetabular component up on the far right. There's something called a hemiarthroplasty, where only the femoral head is replaced. And then there's a specialized type of hemiarthroplasty called a bipolar prosthesis, where the femoral prosthesis is used along with an articulating acetabular component, and the cartilage itself is not replaced. There are 2 types of knee replacements that are done. There's a total knee arthroplasty, or a TKA, where the articular surface of the femoral condyles, the tibial plateau, and the patella are all replaced. And then there's something called a unicompartmental replacement, where only the medial or lateral tibiofemoral component is placed. And I have an X-ray which shows what those devices look like. So how important are prosthetic joint infections? Well, infection rates depend a lot on the joint implanted. So hip replacements have different infection rates as compared with knee replacements. And similarly, it matters a lot whether it's a primary or a first procedure as opposed to a revision procedure. So for example, overall, the incidence of infection following a total knee arthroplasty is about 0.8%. But if you break it down compared to with primary arthroplasties compared to revision arthroplasties, rates are much lower, 0.4 to 2% for primaries versus over 5.5% for revision. So it actually makes a difference. Infections after knees are estimated to be about 1.2%, and again, rates are higher for revision procedures than primary procedures. These infections translate into really substantial morbidity for patients. So in 2010 data, the estimated cost for a given patient with a prosthetic joint infection is about $50,000. Multiplied by the total number of patients affected, that's about $250 million. And of course, now in 2019, those numbers are only higher. Besides the cost, it prolongs hospital stays by as much as 2 weeks, and also because these patients require outpatient follow-up and IV antibiotics, there's more outpatient visits, and it just builds on the cost. So there are a limited number of ways that prosthetic joint infections arise, basically 3 mechanisms. So first is direct inoculation at the time of surgery, and this is thought to account for the overwhelming majority of patients, 60 to 80%. Importantly, introduction of organisms at the time of surgery can translate into infections occurring years later. So if you have a very small inoculum of a low virulence organism, infection may not become manifest for a long time. The second mechanism is hematogenous spread from a distant site. That accounts for under 40% of patients. The risk for hematogenous seeding of a prosthetic joint remains for the life of the prosthesis, but diminishes with time as a pseudocapsule starts to form around the prosthesis and making it less susceptible to hematogenous spread. And then last would be contiguous spread from an adjacent focus. So for example, if a patient had had a prosthetic knee placed and then had a fall, an open wound with a superficial infection, that could then spread to involve the prosthesis. I think it's helpful for a classification scheme to look at infections according to the route of infection, according to the timing of infection, so early versus late. So the route of infection we just talked about. The timing of infection typically is broken down into early, which is defined as less than 3 months, delayed, which is between 3 and 24 months, and then late, which is anything after 24 months. Typically, these late infections are the ones that are associated with hematogenous spread. It's also extremely important to consider the factors that predispose to infection. And those, I think, are best divided into host-specific factors and procedure-specific factors. And that's very important in terms of looking at preventive strategies. When you look at host-specific factors, I think that can be further divided into modifiable and non-modifiable factors. So for example, some of the modifiable risk factors are things like obesity, active tobacco use, anemia, and Staph aureus carriage, as well as elevated pre-op glucose. The non-modifiable things, you can't change people's having diabetes, so even though you can improve their diabetic control, they'll still be diabetic. Males, interestingly, are at higher risk than females, and as a general rule, you can't really change that. A high ASA score is also a non-modifiable factor, and some of the other things I have listed on the slide. I'm not going to go through each one. In terms of procedure-specific factors, there are a number of things that are modifiable. So high blood loss can be impacted, and we're going to talk about that in a minute. Really long procedure time, which seems to be linked to having multiple residents participating in the procedure, and prolonged wound drainage. Some of the non-modifiables are longer procedure time, so more complicated procedures, revisions. Those are just inherently longer procedures. Surgeons who do low volumes of procedures, you can't really fix that. Low volumes at the hospital itself. So I want to say a few words about some of the risk factors. So I think that we don't pay enough attention to the importance of smoking as a modifiable risk factor. So data have shown that there are chemicals in tobacco smoke that reduce blood flow to the surgical site, and that can affect blood flow, cause some local ischemia, and can impact local immune response and wound healing. We know that nicotine in particular can cause vasoconstriction and hypoperfusion to the wound, and that can impact wound healing. It's recommended that patients quit smoking at least 4 to 8 weeks prior to surgery and during the perioperative period. And then, of course, we would like to capitalize that and encourage them to continue to be non-smokers, but for at least a month or 2 prior to surgery, they should be strongly encouraged to quit smoking. Rheumatoid arthritis is a really important risk factor, and it's known that both rheumatoid disease itself, as well as some of the immunosuppressant medications used to treat, are risk factors for postoperative infections. There's no consensus on when to stop immunosuppressive medications prior to undergoing surgery, and it's recommended that the orthopedic surgeons, the infectious disease practitioners, and the rheumatologists come up with algorithms at each individual institution. Morbid obesity is also a really important problem. So we know that the risk of infection increases with a BMI over 40, and that can be almost 3.5 times the risk compared with patients who have BMIs under 40. Of course, this is really frustrating for patients because many of them continue to gain weight because of inactivity related to their chronic joint pain. So they often feel like they're in a catch-22 situation. The surgeon doesn't want to do the joint replacement surgery because of their obesity, because of their inability to move. They continue to gain weight. Diabetes is also an important risk factor for prosthetic joint infections. Data show that diabetic patients having hip arthroplasties had almost an 11-fold increased risk of infection compared with non-diabetics. So I think the important thing, since you can't eliminate diabetes, is to try to maximize glycemic control, both preoperatively as well as perioperatively and postoperatively. This slide lists a number of other additional risk factors that have been identified, and I will just give the disclaimer that this doesn't include all of the risk factors that have been identified, so it's a little intimidating, all the things that can impact our patients' overall risk. Psoriasis is an important risk, probably because those patients have a higher likelihood of being colonized with staph, in addition to skin breaks and poor wound healing. Poor nutritional status is something I feel we often don't pay enough attention to as well, probably because hypoalbuminemia is an important risk for poor wound healing, with studies showing an albumin less than 3.5 being associated with almost a 7-fold risk of developing a major wound complication. Advanced age is a risk factor, and I think it's hard to define exactly what advanced age looks like. Most of us would consider advanced age as being older than we are. Anemia is also a very important preoperative risk factor, and this is one of the modifiable risk factors. And you can see data showing that anemic patients had higher risk of infection, but almost double those who didn't have anemia. And then, as I'd mentioned before, bacteremia obviously is a risk factor for seeding of prosthetic joints, which for reasons that are not well explained seems to affect knees more than it does hips. So shifting gears a bit to the microbiology, in general, similar to what we see in other disease states, Staph aureus is a really important cause of post-op infections. So coagulase negative staph are among the most important pathogens that we see, followed by Staph aureus, which would encompass both MSSA and MRSA. And then there's sort of a variety of other organisms that are listed: mixed flora, strep, gram-negative rods. Very importantly, for patients who've had shoulder arthroplasties, P. acnes is a very important pathogen, and that affects about 16% of infected shoulder arthroplasties compared to less than 2% of other joints. And that probably relates to the distribution of P. acnes colonization. So the area around the axilla anterior to the shoulder has higher levels of P. acnes colonization compared with other body sites. It's important to keep this in mind because when taking care of patients who've had infected shoulder arthroplasties, you need to ask the microbiology lab to hold the cultures for 2 weeks because this can be a slow-growing organism. Interestingly, P. acnes affects men more than women, and whether that reflects differences in colonization remains unclear. And then occasionally there are some very unusual organisms that can cause prosthetic joint infections like Pasteurella, Capnocytophaga. We see rarely Mycobacterium avium and other atypicals. And then there are case reports of Lyme causing prosthetic joint infection. So important to keep in mind for patients with culture-negative prosthetic joint infection in an area of the country that's endemic for Lyme, that Lyme can actually do this as well. So how to make the diagnosis of prosthetic joint infection? There's actually no real gold standard to diagnose infection, but generally it's a combination of factors, including clinical suspicion. So a patient who has a painful, swollen, warm prosthesis with an effusion should be evaluated for infection. Synovial fluid analysis is a crucial part of the diagnostic workup. Serologic tests looking at sed rate and C-reactive protein. Obviously, culture results, both of joint fluid and of blood. and then histology for patients who have synovial biopsies, and that can actually help to determine the surgical approach to these patients. There also can be molecular diagnostics on synovial fluid with PCR testing to help identify organisms. So the Musculoskeletal Society, or MSIS, has slightly different definitions for prosthetic joint infection as compared with IDSA. And I've highlighted the overlapping features, which include a sinus tract communicating with the joint, as well as a pathogen that's been obtained from at least 2 separate samples from an affected joint. Some of the other supportive data would include an elevated SED rate and C-reactive protein, and the organism itself can help you lean towards or away from prosthetic joint infection. I think most providers would say that a sinus tract draining to the joint alone is highly suspicious for prosthetic joint infections. Looking at the results of synovial fluid, it's important to remember that the threshold to consider a joint to be infected based on cell counts depends on how far out from surgery the patient is. So in the non-postoperative period, a white cell count or a nucleated cell count over 1,700 or having more than 65% polys is consistent or suspicious of prosthetic joint infections. It depends on whether you're talking about a hip versus a knee. So 1,700 white cells would be for a knee, more than 4,200 white cells for a hip. For patients who are much farther out from the original surgery, the white cell cutoff is higher, so over 10,700 nucleated cells, and it doesn't matter if it's a hip or a knee, with more than 89% polys is considered suspicious for prosthetic joints. So there are a number of factors to take into account when interpreting the results of synovial fluid analysis. It's also important to remember that the SED rate and C-reactive protein are helpful, but certainly not pathognomonic. So if you look at the performance characteristics, when you look at CRP and SED rate together, the sensitivity is very high, but the specificity not so much to make a diagnosis of prosthetic joint infection. And the thresholds that are typically used is a SED rate over 30 and a C-reactive protein over 10. The use of imaging study is generally discouraged by the IDSA guidelines. The American Academy of Orthopedic Surgery says that you can consider either a tagged white cell scan or a gallium scan if there's diagnostic uncertainty, but that is based on fairly weak level of evidence and only got a moderate recommendation. But in isolated circumstances where there is concern but a lot of diagnostic uncertainty, these tests can certainly be done and interpreted in the right context. One of the newer developments in terms of diagnosis of prosthetic joint infection is a molecule called alpha-defensin, and this can be measured in synovial fluid. There was a study published in 2014 where they looked at 149 synovial fluid aspirates that were tested for both alpha-defensin and C-reactive protein. Patients were considered as being infected based on the Musculoskeletal Society definitions. They looked at 112 patients with aseptic joints, 37 patients with prosthetic joint infection, and the performance characteristics were quite good, with 97% sensitivity and 100% specificity for diagnosis of PJI when synovial fluid alpha-defensin was combined with CRP. So this is a very helpful test. Our orthopedic surgeons use this all the time. It's a commercially available test that's a send-out. And as part of the whole package, in addition to measuring alpha-defensin, the test will measure cell count, C-reactive protein, culture and occasionally molecular testing as well. And this can be extremely helpful in outpatient diagnosis. In terms of obtaining cultures, the IDSA guidelines recommends at least 3 and ideally 5 to 6 intraoperative tissue samples, as well as we like to send a sonication of any explanted hardware to maximize a microbiologic diagnosis. The optimal duration of the optimal duration of incubation isn't really clear. It's recommended to hold the cultures for 14 days when there's concern for P. acnes. Otherwise, a 5-day incubation should capture the vast majority of organisms. And then the sonication of explanted prosthesis, which basically helps to remove any organisms that may be adherent, isn't validated for fungal infections or mycobacteria, but is extremely helpful to improve sensitivity and specificity for diagnosis of conventional bacterial organisms. In terms of treatment, surgical treatment can involve several different types of procedures. So IDSA guidelines recommend considering retaining the prosthesis. So that would be what they call an incision and drainage with just exchange of the polyethylene components. That would depend on a well-fixed prosthesis, the absence of a sinus tract, and then early infection. So within 30 days of placement of the hardware originally, or within 3 weeks of appearance of infection. This is a good option for patients who are high risk for surgery. Is definitely not appropriate for all patients. The American Academy of Orthopedic surgery guidelines adds that they do not recommend this procedure for patients who have MRSA because those organisms, that organism can be harder to eradicate. The Orthopedic Society also points out the importance of being able to close the wound with an adequate soft tissue envelope, and so they won't try to retain the prosthesis if there's concern that it's not going to heal well. IDSA guidelines for antimicrobial treatment depend a little bit on what surgical procedure is chosen. So I've just selected out certain instances to review here. So for staphylococcal prosthetic joint infection and patients who've had debridement with retention of the prosthesis, it's recommended to administer 2 to 6 weeks of pathogen-specific antibiotics. So for example, in MSSA, those patients would get cefazolin or oxacillin. For MRSA, they would get vancomycin along with rifampin, and that would be for 6 weeks. And then they would be continued on an oral regimen that included rifampin for 3 months for patients who had hip infections, 6 months for patients who had knee infections, and then indefinite oral suppression with an agent other than rifampin. So for example, patients who had MRSA might get doxycycline alone or Bactrim alone, and that decision is based on antimicrobial susceptibility, patient allergies, renal function, and other factors. That duration of chronic suppression is one of the areas where we need a lot more research. Most of the orthopedic surgeons would prefer to have their patients on antibiotics forever. As ID providers, we obviously don't like the idea of leaving patients on antibiotics forever. And I typically bring the patients back every couple of months and we review risk, benefit, other medical problems. For patients who've had a 2-stage exchange where all of the hardware has been removed, they get 4 to 6 weeks of pathogen-directed therapy. There's no need for rifampin because the rationale for rifampin is to penetrate biofilm on prosthesis. After the 6 weeks of antibiotics are completed, antibiotics are stopped, the central line is removed, we follow the patients, and then make a decision with the orthopedic surgeon about when a new device can be implanted. And then for other organisms, non-staph, there's no need to add rifampin. They get 4 to 6 weeks of pathogen-specific therapy, and then the decision for chronic suppression is really based on retention of hardware or not. And then I want to say a few words about prevention, because since this has such important consequences for patients, we really want to do all we can to prevent these infections. So it's fairly standard to have laminar flow operating rooms. Our institution has worked extremely hard at preventing both pre-op and intraoperative hypothermia, because we know that this is associated with impaired microcirculation. So patients get bear hugger warmers put on prior to surgery. There are efforts maintained to keep the temperature in the operating room warm enough so that the patients don't develop hypothermia. All of our patients routinely get staph screening preoperatively, and that can be done either in the outpatient setting or in the inpatient setting. So, for example, hip fractures where patients need arthroplasties, that can rapidly be done with PCR testing as opposed to conventional culture methods. We decolonize all of our patients who are Staph aureus carriers with 5 days of mupirocin, and then everybody gets nasal povidone iodine at the time of surgery, just in case they didn't follow the decolonization regimen. In addition, patients have full body wipes with chlorhexidine the night before and the morning of surgery. We work really hard to ensure appropriate antimicrobial prophylaxis based on SCIP guidelines, which says that patients should get their antibiotic completed within an hour of incision. That's really easy for patients who are getting cefazolin prophylaxis because it's a quick push. More of a challenge for patients who require vancomycin, either because they're known MRSA carriers or because they have a cefazolin or a penicillin allergy. We've also worked really hard to try to get allergy testing and desensitization where possible for patients who carry a penicillin or cephalosporin allergy. We have found that many patients who report these allergies, in fact, are not allergic. And we really feel that cefazolin is a better drug for prevention of infections. It's fairly routine for the surgeons to use antibiotic-impregnated cement, and studies have shown that combinations of systemic antibiotics with antibiotic-impregnated cement will prevent infections in high-risk patients, and that looked at those with diabetes as well as patients undergoing revision arthroplasty. The data in general to support this are not nearly as robust as we would like, and I think it's an excellent area for more research. There are problems with antibiotic-impregnated cement, including allergy, concern about emergence of resistance, and there's some concern that it may actually degrade the integrity of the cement and cause aseptic loosening down the road. As I mentioned earlier, since anemia is a risk, we try to manage preoperative anemia, ensure good glucose control, encourage smoking cessation, nutritional screening. I had showed the data earlier about the bleeding complications, and so one of the things that can be done to manage intraoperative bleeding is the use of tranexamic acid, or TXA, which is an antifibrinolytic agent that's been shown to reduce the need for intraoperative transfusions in both elective hip and knee surgeries. This showed a relative risk of 0.52 compared with patients who didn't get TXA, and no increase in thromboembolic disease postoperatively. I also want to say a word about urinary tract infections, because one of the things that's sort of gotten into the lore of orthopedic practice is the need to screen patients for urinary tract infections prior to surgery. So there's been a lot published about asymptomatic bacteriuria, and there are several strong recommendations not to screen for that. So there was a very nice study that was published back in 2015 that actually showed asymptomatic bacteriuria to be a risk factor for development of prosthetic joint infections. So this study looked at almost 2,500 patients, 12% of whom had asymptomatic bacteriuria, and that group actually had a 1.7% risk of infection, which was higher than those who didn't have infection. Okay, I want to do this slide again. Okay, So there was a study that was published in 2014 that looked at the need to screen patients for asymptomatic bacteriuria prior to proceeding with arthroplasty. So this study enrolled just under 2,500 patients and found 12% of them had asymptomatic bacteriuria. Overall, for all comers in this group, the rate of prosthetic joint infection was 1%. The rates were significantly higher in patients who had asymptomatic bacteriuria as compared with those who did not, 4.3% versus 1.4%. The really interesting findings of this study, however, were that the organisms that grew out of the urine cultures were not the same organisms that were recovered in patients who went on to develop prosthetic joint infections. And equally interesting, treatment of urinary tract infections did not impact the rate of prosthetic joint infections. So finding asymptomatic bacteriuria is a marker that a patient is at higher risk, but treating it doesn't mitigate that risk. And recommendations are quite strong now that advise against routine screening for asymptomatic bacteriuria prior to prosthetic joint infections. So we struggled to try to get our orthopedic surgeons to implement this recommendation. Of course, it's important because we don't want our patients developing C. difficile colitis and having diarrhea and potentially contaminating a fresh hip incision. So this slide just summarizes a variety of preventive measures that should be considered. And I think it's very important to emphasize the importance of a good visit with the patient's primary care physician, a really thoughtful review of all of the medical issues, encouraging smoking cessation, weight loss if important, doing a good assessment of skin exam to make sure there are no open areas, cellulitis, intertrigo, screening for sleep apnea with a quick stop bang assessment because that also can be a risk factor, looking at total white cell count, and that can be used to then calculate lymphocyte count, lymphopenia, again, yet another marker for infection, preoperative screening for Staph aureus that I mentioned, looking at diabetes control, and ensuring appropriate cleaning with chlorhexidine wipes. That summarizes my talk on prosthetic joint infections.